I want to welcome everybody this evening's Dean's Lecture. It's a little unusual that we do it out of the semester, but Dr. Varkey was available and we thought it would be a tremendous opportunity. Dr. Pratibha Varkey, I knew her when she was a distinguished health services researcher at Mayo Clinic. And after really making a mark in the field of quality improvement and health services and outcomes research, she took a very interesting job in Texas, heading a health organization there. And we were lucky enough to recruit her to be the CEO and president of the Northeast Medical Group. And I'll let her tell about her own group, but I know that she's doubled the size of this group in the less than 3 years that she's been in Connecticut. So here's an individual who comes from academic roots, tremendous legitimacy, and I'm going to turn it over to Howie and Mark to convene the evening.
Thanks, Sten, for having us all, and really thank you, Pratibha, Dr. Varkey, for doing this with us. You know, you and I have known each other now for a couple of years. You've been meeting with our students, and you know, I work with your physicians in the Yale New Haven Health System in many different capacities that I play there. But what is most amazing about you is, as Sten said sort of before we began this, is that you are a true scholar. You are an editor of textbooks, a writer of numerous peer-reviewed journal articles. You're an expert in the quality space. You're an expert manager. You have a public health degree. And here we are at this time in a pandemic where all of these skills and all of these tools in your toolkit are so important to what you're doing now. So let me give you the opening to just talk a little about your current role, and then let's come back to talking about how that role is interfacing with the current pandemic and the sort of you know, Connecticut community at large.
Howie, before we dive in, let me just tell everyone who's in the audience, the virtual audience at this point, that if you guys have comments, questions, or thoughts, please put them in on the chat line, and they will then be relayed back to us in real time by people who are monitoring the chat line. And so just feel free to pop them in whenever it's right, and we'll work them into the conversation. Okay, sorry for the interruption.
Thank you.
Well, let me begin by thanking all of you for making time. I know it's been, you know, an incredible, unique, challenging, but also inspiring year for many of us in public health and healthcare, in really being part of, you know, helping our communities manage this pandemic. And I'll thank Sten for inviting me to join all of you today, and Howie and Mark for facilitating the dialogue. I'm really hoping this will be conversational, so feel free to shoot questions forward, and we'll make sure we try to answer as many as possible and weave in themes as I converse. So I'm the CEO and president of the Northeast Medical Group. We are the physician foundation for Yale New Haven Health. So we are the home of all the employed physicians for the system. At present, we are about 2,200 in sites, about 1,100 plus clinicians, about 40 plus specialties. I'd call it a hybrid model. So it's community physicians in an academic health setting. I'd say at least a third to half have been trained in Ivy Leagues, and we are a close cousin of Yale Medicine. And so we very closely partner with our colleagues in Yale Medicine in delivering care. We are about 25% primary care, about, I'd say our fastest growing component is the hospitalists, a component of NEMG, about 35%, and then about 40% of us are specialists. And we practice in about 140 sites, so predominantly across the shoreline in Connecticut, but also into Westchester, New York, and Westerly, Rhode Island. All of this will become significant as we talk about managing an evolving pandemic, with a lot of change across 140 sites, where there were regional differences, particularly in the first wave of the pandemic. We're also the home of the ACO, so we have a MSSP Track 1 ACO and several value-based contracts. I'm an internal medicine and preventive medicine physician, and I'm trained in public health, particularly in the field of healthcare management, and so part of the faculty at the school. And spend a lot of my time in quality improvement and figuring out change management and rapid cycle improvement and inspiring physicians and students to be the best they can be. And all of this, I think, helped me, along with obviously a tremendous amount of teamwork across Yale New Haven Health in managing this crisis. So thank you, and look forward to the dialogue.
Thank you. So you already alluded to some of it, which is that there's a lot that goes into coordinating information flow during any time, and particularly during a pandemic. One of the things that struck many of us, and I was working with a group with the management of the COVID floors, and working with a lot of your hospitalists and a lot of the Yale Medical Group and a lot of our nurses, so 3 different organizations, was that there was a challenge in terms of information flow between the different groups. And I wonder for you in particular, where what you alluded to is that, look, Western New York, Westchester was one of the first hit regions of the country. One of the largest subsequent outbreaks was in Westport. And up until very, very recently, our practices in the eastern part of the state in Rhode Island were almost completely unaffected, and now recently really hit very hard, relative at least to the first wave. And so how do you manage information flow in a practice like that during a pandemic?
Yeah, I think it was actually one of the biggest lessons learned during the pandemic. And I think one of the things we did very well during the pandemic, but lots more in terms of ways to progress communication flow. And I'll address it as communication within the health system, communication within the group in terms of 140 sites across outpatient, inpatient, and specialties, but also another arm, which is communication to patients directly. And something that I enjoyed tremendously, which is communication to our vulnerable patients and bringing them back in through risk stratification. So really using some of the techniques that we have studied in terms of informatics and risk stratification and a population health approach in bringing people back. And I'll address each of those components. So in terms of communication, the usual story in the physician realm is that it takes 17 to 20 years for things to translate to practice once research proves that some technique or treatment protocol is effective. That was very different in the pandemic era because we were essentially transferring information and imbibing it almost on a daily basis, and so the tremendous amount of flexibility in understanding what's working in one area or in one institution and in some trials and then translating it to real life and practical ways of taking care of patients. Very different from a traditional approach in medicine in waiting for randomized controlled trials to provide us information and guidelines in terms of treatment protocols. So we had this raging virus, and a lot of focus initially, at least, was in the intensive care units and potential treatment protocols. So there were 2 streams, and they're a little contradictory, but really both were critical in terms of ensuring that communication flowed and that really translated to appropriate care during the pandemic. So in one way, it was very flexible, and it was sort of a flattening of hierarchy in terms of transmission of information. And in another way, it was very structured in terms of having an incident commander at the system level and then having information flow into each of the regions. And both were critical. There were some things that had to be transferred in a very structured approach. For example, PPE guidelines around that, certain treatment protocols that were relevant across the system and the medical school, occupational health related issues as it relates to employment, So those were in a very structured fashion. There were 7 a.m. calls where incident commanders of each of the regions in each of the hospitals and NEMG and YM would get together, and then the information would flow. There were also town halls that Marna led, that Nancy Brown led, that each of our CEOs led in each of our regional delivery networks that helped with flow. And very different in the sense that what traditionally might have taken many meetings to transfer information really changed into, as I said, a flattening of hierarchy and team huddles. So we would have a huddle at 7 a.m. and we would have a huddle at 1 p.m. And between the 7 a.m. and 1 p.m. meetings, a ton of decisions would have been made in terms of a change in workflows, and then that would be communicated. I actually appointed one of my senior vice presidents, a physician leader, in charge of communication, because I really needed a person who understood the medical and public health issues, but also was able to communicate very thoughtfully and very rapidly, almost in a daily fashion, sometimes even twice daily. And so there would be a stream of communication that came in from the system, and then it would be enhanced or modified based on regional issues at the local level as well. And that was important. The regional differences and communication was important because, again, when Greenwich and Westchester were having a huge outbreak and a huge census in the hospital, our colleagues in Westerly and New London in the northern part of Connecticut were really not having any patients. And so, how do you keep that information? Now you want to keep those sites open. You want to close down some of the ambulatory spaces in the Westchester and Greenwich region to provide capacity and transfer of infrastructure. And maybe you want to bring in New London folks to help with the Greenwich ICUs. And that's essentially all of that was happening in a very studied, careful, but very, very rapid way, and in a very cohesive way. And it was frankly that flattening of hierarchy and deliberate but rapid communication that occurred. And we would actually announce at the start of every town hall and every email, this is December 3rd, 10 a.m. And the idea was at 12 p.m., if a new email came out and the information was different from the 10 a.m. email, the 12 p.m. one would be the one that people needed to follow. And people began to adapt very rapidly in terms of being on top of their emails. Town halls that might have had 300, 400 attendees in Northeast Medical Group had 1,000 plus. And so it was just incredible communication and bi-directional communication, and issues that were happening in the front line were transmitted very rapidly to the leadership, and then back and forth. And a lot of I'd say PDSAs going on from my QI world. It was really that lot of rapid cycle improvement, not waiting for perfection, but getting it as close to good as possible, and then improving as we went along.
And then while you're doing all of that simultaneously, as you already alluded to, you're shutting down ambulatory sites, but also facilitating telemedicine across the enterprise. And this, to me, also is something that I think to the average person out there, you don't see that it's not just one piece that's moving, but you have to, number one, sustain the business, which is a business, and it can't just be allowed to go out of business during this time. But you also have to meet the needs of a community that has not been without their physicians ever. We've always known that we could get into the office if we had to, if we had a problem, we could reach someone. And in many cases, the sites were frankly closed, or at least very limited to access. And you had to introduce telemedicine in a vast way. And I'm curious to know how you managed both those pieces at once, because people think about hospitals doing their piece and they think about physician practices doing their piece, but you're doing both at once.
Yeah. It was actually a little bit phased because what happened is when we noticed the huge inpatient census and some of our hospitalists in Greenwich actually got infected with COVID, this was again in the early phase as we were trying to understand as a healthcare system, what PPE was and, what the protocols were in terms of taking care of patients and what, frankly, the symptoms were of patients that were showing up with COVID. So there was a PPE dialogue. There was a tremendous 90% of visits, ambulatory visits, we noticed were getting canceled by patients because they were hesitant to come into our world because of fears of getting COVID and really the unknown issues as it related to the pandemic, given some of the media dialogue around it. And then there was a need to frankly redeploy ambulatory physicians to the inpatient setting. So we had primary care physicians working as hospitalists. We had hospitalists working as intensivists. We had cardiologists and pulmonology fellows working together as intensivists. We had people who had not set foot in the hospital in 20 years going overnight and practicing in the hospital setting. So all of that had to happen. And as we looked at it, it became very evident that we needed to consolidate from our 145 sites to a much more controlled sort of number of sites. So we closed to about 35 sites in March. That was, of course, we had to announce it overnight. That did, of course, cause a lot of trepidation among folks that wanted to continue their practices, that were wondering about, what the long-term impact of this, that were worried about patient, issues. And then in 48 hours, we had to train over 500 physicians to use telehealth. And in all age ranges and folks that were obviously very hesitant, some of who did not have the technology or iPads to do it. And so it was, extensive boot camps in collaboration with YM and training all of our physicians and staff, because it's not just physicians, it's the staff that are rooming, patients as well that needed to be trained, and then setting workflows and understanding how these visits would be built. As well. And frankly, even going ahead of the payers, before the payers announced that these visits would be paid for by telephone or video visits, we had to do this basically just based on understanding the public health impact of this and the fact that we had to consolidate practices. There was another interesting thing that happened. Which was figuring out, we have respiratory, symptoms and we have non-respiratory symptoms. So in the 35 sites, should we be accepting all patients in all 35 sites? So we actually started improvising and created respiratory sites versus non-respiratory sites so that, things would be safe. Just like the grocery stores did, we had senior hours and, high risk, sites. The pediatricians were adamant that we didn't want a measles outbreak or a mumps outbreak. And so we needed to make sure that the vaccinations were kept, up to speed during the height of the pandemic. So, a lot of things like that. And then, drive-through testing, using the tents for testing. So a lot of things occurred, not necessarily all in one day, but certainly within a few weeks, transformation in terms of the way we practiced.
And let me ask you this, and I don't want to put you on the spot because this is a question that I think would hit me a little bit, but I'm shocked at how little we sort of anticipated right from the beginning. Like we did a great job clearing out the hospital, creating capacity, doing a lot of those things. But boy, the amount of information flow was so fast, so furious, so many things changed that I wouldn't have expected as fast. What are 1, 2, or 3 things that shocked you the most when you look back at what we've been through and what we're even doing right now? Are there some things that surprise you the most?
Yeah, my surprise might surprise you, which is, what we thought was telehealth would be very well accepted by patients. And of course, we had, I think over 200,000 telehealth visits in a matter of a few months, as also with YM. But as soon as we opened face-to-face visits back in, I think it was around June, patients wanted to come back to see their physicians face-to-face. That really surprised me. And we're talking about older folks, we're talking about, all generations, we're talking about different kind of diseases. And to a point where until about a month ago, the number of, the proportion of telehealth visits were, down to about 10%. Even though we were championing it and there was a lot of communication and more, health education and awareness of telehealth. So that was a surprise to all of us in the sense that, of course, it was accepted, but people really like to see their physicians face to face. And what works is if you, and this is what we're figuring out right now, if there's a good mix of telehealth and face-to-face, I think patients find that more reasonable than only interacting virtually. And for some of them, frankly, it's akin to a social visit as well, with somebody that they trust and that, that they've had a longstanding relationship with. So that was one surprise that we had not anticipated. The second was during the first wave, we had about, my team was very innovative, from a population health perspective, reached out to about 40,000 vulnerable patients, so risk stratified, to ensure that the right people were being seen. And in the first wave, what surprised us tremendously was we were the first point of contact for many people, vulnerable patients, so either families had moved to Florida or maybe they were isolated in their homes and they had really not had any contact with anyone else. And 70% of them, we had to bring them back to see, one of us either through telehealth or face-to-face. So, the traditional mode of waiting for patients to reach out to us does not really work from a public health standpoint because we've got a large number of vulnerable patients and, patients with chronic diseases that need care. And some of them felt they didn't want to disturb the doctors because we were, taking care of much more serious COVID issues. So I think that dialogue became important, and we actually started having patient-family town halls. Just like we were doing Zoom town halls with our providers, we started doing that and advertising that through social media. And that really brought back patients and re-educated them on telehealth and some of the public health measures around COVID. So that was a huge lesson for us. It was particularly joyful to me because I'd never done that, reaching directly to large, 1,000 patients and directly communicating with them. So that was another lesson learned that I think, the COVID pandemic provided us in terms of how we can approach public health.
I'll just say this right now, you're a fantastic communicator, so they are lucky to have you in that role. This is a time when valued communicators and people that are able to be honest, sincere, and at the same time able to talk at a level that people can understand is in short supply. You do a great job with it. I'm going to hand it off to Mark with one question to you first before that you may or may not know is, are there other groups that are similar to NEMG and having such a large footprint in hospitalist medicine as well as being a multi-specialty group? Is this unique? Because I'm just, I guess, naive to this.
Yeah, I don't know the true answer to that, Howie, but I suspect that, and I've worked in other health systems that, have similar multi-specialty groups. I actually ran one in Austin. And so, yes, when you're part of a health system, typically hospitalists are a large part of it. And particularly with the evolving, specialty of hospitalist medicine and the tremendous impetus given to, outcomes when treated by somebody who's familiar with inpatient medicine versus not. I think, that's a rapidly growing field. In LNM, Lawrence and Memorial in New London, it is actually a team that is it's a contract with a private group that has a large footprint, Team Health of hospitalists across the country. So, there are multiple models. I think in the academic world, I'm not sure if such a large footprint of hospitalists exists in typical academic medical group settings.
Great. I'm going to turn it over to Mark now.
All right, that sounds great. And we will segue now from the inside story in the health system to some of the kind of broader ripple effects that manifest themselves through patients and public perceptions and the whole range of broader issues that are induced by the pandemic. But before we make that transition, Camille, are there any questions or pressing comments from attendees?
I have not seen any come through the chat, but if anyone has any now, I invite you to reach out with them.
Yeah, again, feel free. We want this to be interactive and participatory. So if you guys have things to write, please write them into the chat room, and then we'll relay them that way, just to control the flow a little bit. All right. Well, those are coming in. Let's start making the transition, and that may also help us to think more about issues that are kind of front and center as we move from a little bit of the history more to the contemporary time. So you already talked about this at one level, which is the challenge of recapturing patients who were either because they were afraid or because they were deferring to other patients who they thought had higher needs, kind of got separated from the system, and they got separated from their regular routines. And the normal pattern of seeing clinicians got disrupted and broken in the extreme when whole practices get shut down. Once we got through the spring, everyone breathed this sigh of relief. We'd been through the crisis. It wasn't quite as bad a crisis as we thought it was going to be. We'd made it. The summer looked pretty good with relatively low prevalence rates. But what's happening now with what we call the second surge or the second wave? How are people equilibrated? Because it doesn't quite feel like a crisis to people in the same way, but it is every bit as dramatic and consequential for the system. So how do you guys manage that part of the process?
Yeah, I think that's a very insightful question, Mark. I mean, the first wave and the second wave, even though, we're separated only by a few months, are quite different, in terms of the impact on the system and the impact on the healthcare workers and clinicians and frankly, patients as well. So on one hand, the first wave was definitely a crisis mode. And, you've got energy flowing, you've got, a bit of uncertainty, quite a bit of uncertainty. Everyone's problem solving rapidly. But you also have a feeling that this was, many people called it, it was my mission. This is why I joined public health or healthcare or became a physician. And, physicians, who were redeployed to the hospitals voluntarily stayed in Airbnbs and hotels, and we were providing hoteling as well, stayed separate from their families, and everyone was committed. People were driving from New London to serve Greenwich and, all of those things. The second wave, it just feels much more long and drawn out, and a feeling that this is not ending and probably not for another 6 months or so. Of course, the vaccines, I'm sure we'll talk about it here in a second, is the light at the end of the tunnel and the beginning of, new hope. But there's a lot of fatigue. There is also, disappointment that this is just long and drawn out. And frankly, just the social elements and personal elements come into play very different from the first wave, where, for 2-3 months, people can handle it. But for a year of not seeing, many physicians have not seen their families, their elderly parents. They don't have the social outlet of either going away physically on vacation. Many of us have been 24/7 on, there is no concept of vacation or weekends anymore. We're all texting each other, 6 a.m., 7 p.m. I mean, it's just never ending. And then the other piece, so that's the social element, and coming back to seeing outpatient practice, outpatients, and the transformation phase of the recovery, which is basically let's get back to normal, side by side with, oh my God, another second wave of COVID. However, we don't want to shut down our ambulatory practices because we know much better in terms of how to handle patients. Not all of them need to be in the ICU. Not all of them need to be on ventilators. So you've got many more patients, in the med surg units being handled by hospitalists, high flow oxygen cannulas versus ventilators. And we're currently managing just in NENG 1,900 COVID patients in the outpatient world, not even talking about the inpatient world, in addition to all of the visits that we're seeing. In fact, our ambulatory visits are over 100% of baseline, simultaneously. So you've got a lot of weekend calls, you've got a lot of calls coming in, plus all these visits, and a lot of community spread. So what we're seeing is spouses that are not healthcare workers, exposing healthcare workers, and hence they have to be quarantined. And about 15% of our staff currently are on FMLAs or leave of absences or are in quarantine. Very different from the first wave. And so you've got that staffing issue. You've got a long drawn out pandemic with no vacations or time off. And then you've got the recovery and transformation phase, and you've got COVID going on. So all of that together makes for a very, internal fatiguing, dialogue, and we're trying as much as possible to help our colleagues and our healthcare workers stay engaged and help them in managing some of the grief associated with the loss of, the social infrastructure and this sort of prolonged pandemic. So it's much more complicated in a different way. It's not as much of a crisis in running around, but it's just a long drawn out, pandemic. But I think, again, with the vaccines being shipped out yesterday, there's, hope on the way, and there's a lot of excitement and I think new energy that we'll see in the coming few weeks.
So, yeah, as you were describing things, my heart just ached for everyone who's in the system, who've just been going for so long and so hard, and we all know the feeling because we've all been doing our own versions of this, but it's hard to fully envision the weight of that burden carried for long time periods. Initially, when the first wave hit, there was, of course, this tremendous outpouring, and healthcare workers were everyone's heroes, and thank you signs were in the windows of every building, and people walking down the street would thank anyone who was dressed up in scrubs, and it was like this outpouring of appreciation because it was a crisis, and it was like the front line, and we all appreciated that. But as this goes on, does that same level of public appreciation of clinicians feeling like their patients have their back while they're dealing with these things, does that also attenuate, or how are relationships between clinicians and patients at this point?
I think, for folks who have been seeing patients over a long-term period, I used to be a primary care physician and a preventive medicine physician when I practiced at Mayo. Patients become like your family. You know them, you see them through various stages of life. They see you through various stages of your life. And it becomes a very long-standing relationship. Same with specialists who are managing chronic conditions and patients. And so, that relationship is very strong, and it frankly helps. It's a bidirectional supporter of relationships, and we derive strength from patients, and hopefully they derive strength from us as well. I think that's very much alive and well. We did see much more explicit outpouring of appreciation in the first wave, but I don't think that has diminished. But I don't, again, I think we've kind of gone back to normal, and we're all trying to go back to normal, and so that's a little bit different. I am encouraged by, I don't know if you've read about the Fauci effect on medical school applications.
Yes, right.
And, about 20%, 18% AAMC says, an increase in terms of applications to the medical school. And that is amazing. I would suspect no less with public health as well, in terms of NPH programs, informatics. I mean, all of this. When I trained in preventive medicine, one of my ideas was to do the EIS fellowship, the Epidemiologic Intelligence Service fellowship at CDC, right after my preventive medicine fellowship, because I really wanted to be part of an outbreak. Did I really anticipate this? No, but I guess, it's been interesting. So I suspect, the public appreciation of the students' appreciation of public health and medicine and nursing is going to be much higher, especially as we're seeing all these, increased admissions. So to me, that's related to the question that you're asking in terms of public appreciation of it. I think we all are in it together. And so I hope, very often healthcare workers, including public health professionals and physicians, were sort of in the background taking care of patients. It's the first time we've actually been in the front of the war, so to say. And we are very grateful to our patients in appreciating that and coming back to support us as well.
That's great. So one of the
Mark,
great,
we do have a few questions now. if you
excellent.
want.
Let's drop some in. Go ahead, Camille, fire away.
Okay. Starting kind of more in the chronological order of the pandemic, the question is, did we overreact in deferring elective care and therefore harm people in need of surgery or chronic disease conditions? And might we have used testing to keep practices open, or was there not enough testing available?
Yeah. In the first wave, we did not have adequate ICU beds, and we were essentially converting conference rooms and some outpatient areas and ambulatory surgery centers to accommodate these patients. We had tents, and so it was just impossible to keep elective surgeries going, while we had this huge inpatient census. It is very different right now. The inpatient census is still very high, but it is not at the point where it was during the first wave. So to be able to manage the inpatient census, to provide adequate care to the inpatients, to have adequate healthcare workers, provide appropriate care, we had to make that decision. At that time, I think it was the right decision. I think we are armed with more knowledge and different knowledge currently. I think the virus is also behaving a little differently this time. Testing also was not as available. Remember, there was also a huge dialogue about PPE shortage, and we were managing that adequately, fortunately, in this system, but that was not the case elsewhere. So it is quite different between the first wave and the second wave, and I think we did the best we could with what we had in the first wave.
And then there's another question moving into the phase when you were using a lot of telemedicine. Did you notice racial disparities in the uptake of the use of telemedicine?
We didn't specifically look at telehealth. That's a very interesting question, and I'm actually going to take it back to my team. We didn't specifically look at that question as it relates to telehealth, but we did look at social determinants of health and racial disparities as it relates to taking care of COVID patients across the system. And we did not, I'm very thrilled to report that in this system, we did not see any differences in terms of care that was provided or outcomes. We do notice, particularly in the second wave, that we do have more community exposure of COVID occurring in some of the ethnicities and in some of the populations that have disparate social determinants. So that is one difference that we're noticing.
And then the latter two questions focus more kind of on communication and information about vaccine distribution.
Right, so let's hold those for a second, Camille, because we'll segue to that in just a moment. So hang on to those questions.
Can I, Mark, just make a comment on communication? Yeah. I think Howie raised that, and Mark, you also raised that. I think one of the things that we learned was the power of social media in terms of communicating with the patients very rapidly. We had never done that. I mean, were we aware of that? Sure, but we had never seen the engagement of patients and families in social media as we've seen during the pandemic. So when we had to announce that we are consolidating clinics, we announced it. When we said we have telemedicine available, we announced that. When we said we're safe to come back, we announced that. Videos about, hygiene and how we're keeping the environment safe. All of those things took on a completely different meaning during the pandemic. So I found myself working with our marketing colleagues in social media as much as I did with some of our healthcare workers, because that became a huge tool to enhance public health communication very rapidly and seamlessly.
All right, that is excellent because it's the perfect segue. So let's segue now to the vaccine portion of our evening agenda. And on the one hand, as you already pointed out, it's a glimmer of hope. We all breathe a sigh of relief. Someone's actually getting vaccinated. More people can be safe, yada, 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 the whole vaccine narrative. But there's also a counter narrative, which is existing and seems a little more disturbing, which is that when you look at the most recent polling data, including some things that were released just yesterday, it is still the case that about 25% of the public says they will not take a COVID vaccine unless they are forced to do so. That goes up to 33% in communities of color and 45% among Republicans. We'll worry more about the communities of color than Republicans for this particular call, but there are clearly pockets of extreme difference. Now, even among those who say they're going to get vaccinated, 2/3 of the people who say they're going to get vaccinated don't want to do it right away because they're going to let other people get vaccinated first to see if it's really safe, and they're going to have to wait a while. So there are a lot of people who say, I'm going to wait 2 or 3 months, even when the vaccine's available to me. So we have vaccine refusal, we have vaccine delay. And the one cross-cutting purpose, and this is where it really speaks to the social media, is that if you look at groups of people, both the vaccine acceptors, the vaccine delayers, and the vaccine deniers, the one thing they will all say is that the one source of information about vaccines they trust most are their own physicians. About 85% say, I trust my physician on this. So how do we leverage that trust to deal with this huge problem of vaccine uptake, which is going to be a big issue moving forward for us?
Great question, and one we haven't fully figured out, but I'm looking forward to all of your input into that as well. I'd be amiss if I, not share that the vaccine, obviously, and we all know this, but I have to say it out loud, is not going to be the solver of all problems. We still have to practice hand hygiene, social distancing, masking, and testing and quarantine as appropriate. I think what's remarkable is that when we did a survey of healthcare workers across Yale New Haven Health, we've got about 28,000. And we did it by region. I looked at NAMG data, very similar. NAMG data is very similar to the Yale New Haven Health System data, which is about 81% of the folks surveyed that responded to the survey said they were willing to take the vaccine. And when you look at the analysis of the comments as to why they were hesitant, the folks that were hesitant, it was all around the long-term side effects, very reasonable in terms of not having adequate information about that. And I think there was a smattering of responses from younger women healthcare workers, and 70% of healthcare workers are women, in terms of some of the confusion around messages related to, potential side effects related to infertility. And obviously the Hugh Taylor, who's the chair of OBGYN at YSM, is the president of the Reproductive Medicine Society, and is about to make some recommendations and public statements related to that, clarifying that's not the case. But what was wonderful to see is that over 80% of healthcare workers were willing to take that. We, as of today, the vaccine arrived yesterday. There were 5 folks who got it yesterday, 440 or so today, And, we're targeting about 10,000 next week across Yale New Haven Health. So the numbers are amazing. Across Connecticut, we're aiming at about 80% of healthcare workers to get it. I think seeing persons of color, seeing physicians, seeing healthcare workers, seeing leaders getting vaccinated, and hearing their experiences and their recommendations are always going to be important. I think, Mark, you hit it on, just right on the head in terms of the, physician recommendations being very critical to patients. I think, church leaders, opinion leaders, influencers from society, all may be important in different communities that we serve in terms of sharing that information as well. In general, vaccines have about a 70%, acceptance rate. I'm not even talking about COVID. If you look at the flu or any of the others, I mean, so that's always a problem. There are religious reasons for it. There are concerns about side effects. Some of the side effects are confused and to be thought related to the actual illness, all of those things. But again, I think we're at, the initial days, literally, of the vaccine being delivered. I'm seeing much more excitement than I thought. I have more elderly patients and, including family members and physicians that are anxious to take the vaccine than I anticipated. I thought they might be a little bit more hesitant, but they're just waiting to get it. So I think, the hope of maybe, being able to come out of this pandemic with this as one of the tools is there. How it evolves is yet to be seen. So I think it's going to take constant dialogue, more dialogue and communication and clarification. And hopefully we'll reach a tipping point to influence others.
All right, fair enough. Camille, let's go to those other vaccine-related questions.
Okay, the first one is kind of more micro-related. How within Northeast Medical Group are you mobilizing and prioritizing vaccine delivery to your physicians, nurses, and allied staff of your practices?
Across the health system, it's the idea is to vaccinate 80% in 7 weeks, in the next 7 weeks. And it's there is some prioritization in terms of ICU and ED physicians and healthcare workers. It's not even just healthcare, actually. It's anyone, receptionists, transporters, custodians getting prioritized. But otherwise, the plan is to do it through an alphabetical approach in terms of getting people vaccinated, because the last thing you want to do is, let's say I have a clinic site in Guilford and I vaccinate all of them and all of them get side effects. And then, you've got the whole, clinic out and, patients missing their providers. So we want to stagger it across the system, and we don't want the same site, multiple people in the same site to do that. And so I think it's been a very thoughtful approach. One methodology, as I said, we're using in the system is through the alphabetical approach. All in all, we've got a holiday week, holiday weeks coming up, but doing it in 7 weeks, 80% of healthcare workers, I think it's tremendous. And again, we'll have to problem solve as this is rolled out.
Thank you. The next question is on kind of a more macro level. What ways are you using public health communication, and what other ways to collaborate with community leaders, local health centers, hospitals, and even the religious figures that you mentioned earlier to communicate clear and scientific messages about the vaccine and its distribution? And how do you combat misinformation?
Yeah, Rick Martinello, who's our infection prevention specialist and really the guru in terms of COVID and COVID-related medical information, has been playing a lead role in helping guide all of us in terms of management of COVID, and now, with the information surrounding vaccines. I think it has to be done through multiple ways. I mean, one of the first ways is to educate internally, our teams, our healthcare workers, and that is occurring largely through town halls. I have one tomorrow. I suspect most of the questions are going to be vaccine related. I had one 2 weeks ago. All of the questions were vaccine related, and the same at the system, and I'm sure at the medical school level as well. The system marketing department is actually partnering with, obviously, the infectious disease specialists and other health systems as well, like Trinity and Nuvance. And I'm assuming other community leaders to release a series of messages related to vaccine and questions related to that. I suspect we'll see that shortly. They are currently in the works.
All right, so let me take back the gavel again, Camille. One last question, because we're running a little short on time, though we'd love to keep you here for a week. It doesn't seem fair to do that. You already mentioned the open and, at this point, unanswerable questions about long-term effects of the vaccine itself and immunization. But there's also, I think, an emerging set of attention and concerns to, they get different labels, but the long-term consequences of COVID for a subset of the population, the kind of chronic version of COVID. And we don't even fully understand what it is or how it manifests or all the way it's emerging, but where does that sit on the radar screen for your system, given the crises, given the second surge, given the rollout of the vaccine? How do you, where is that in the firmament of topics you guys are focusing on?
It's a big deal, and I'm so glad you brought that up because we don't talk enough about it. There's actually an entire clinic related to, chronic. I can't remember what it's called, but it's basically the chronic COVID syndrome, for lack of a better word. But it is a ton of extreme fatigue. It is a lot of pulmonary and cardiac symptoms that don't correlate with imaging or laboratory findings. It is very unusual. So you've got patients that look like they're extremely short of breath, but it does not correlate with X-ray findings or pulse oxes. Or the other way around, people who are talking and everything and pulse ox is at 60 or 70 or something like that. So we're seeing a range of those. There's also neurologic issues and a tremendous amount of, I guess, behavioral health slash sort of PTSD, effects that I think we will have to deal with, over a long period. And so there are a lot of implications as it relates to all of those things and potentially many others that I've not mentioned. So there is a entire cadre of, there's an entire group of patients that we're following that have those sequelae. And it's a combination of primary care, pulmonology, cardiology, neurology, and PM&R, and behavioral health that are taking care of these patients. But we're still understanding how to do a better job in terms of identifying, diagnosing, and managing these patients.
All right, great. Thanks for those insights. Our time's just about up. Stan, I'm going to hand it back to you for some closing thanks and comments.
Well, thanks to Mark and Howie for excellent moderator functions, and Pratibha, we're very grateful for your spending this hour in an evening with us, as if you weren't busy enough. But I just, when we talked about this, Howie, Mark, and I, we had an instinct that what your experiences have been over the last 10 months would be immensely interesting to share with our audience. And I know I speak for everybody on the call that we have gotten every bit out of it. And I thought it was hilarious that Mark said we'd like to keep you for a week because we want to just keep asking you questions. That's absolutely true. So thank you very much. And I want to remind, if I'm not mistaken, Howie, you have Dr. Varkey coming back to your well-known seminar in February. Is that right?
That is right. I'm looking right now to make sure I know the date. It's the 11th of February. That's always open to anybody who wants to come, and it's on our distribution list.
You read my mind. So February 11th, I think it's the early evening. And if you're not on the routine distribution list, you can send Professor Foreman a note, Howard Foreman a note, and he will put you on. So we do get you back, Pratibha, in just a couple of months. And on that note, I want to wish you a very happy holiday and thank you very much.
Thank you for having me. This was a delight, and look forward to continued dialogue.
Thank you all. Take
Thank
care.
guys.
Thank you.
Bye-bye.